Muhammad. Thank you, Dr. Marwan. First of all, I would like to thank all of you. I would like to thank the chairman of the third international conference of pharmaceutical sciences, and all the committee members, the head of committees, for giving me this a chance to be a keynote speaker in this prestigious conference. And also, I would extend also my thanks for them for giving me this chance also to be a member of the scientific committee of this conference. So just give me a second. Okay, can you see my screen?
Yes, it's okay, but yeah, it's okay now.
Okay, بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. Today we will talk about the first thousand day of the human life and how these days, because these days they have a very important critical periods, how these days can impact the entire life and the entire programming our life and how we will look in the future in terms of our health and chronic diseases. So when we are talking about programming, this start from the conception or maybe before the conception. Uh, so I will cover all these. These are the outlines of my presentation. View the evidence of the protective effect of breastfeeding. Compare breastfeeding and formula composition. Examine the mechanism linking early feeding and later metabolic health. Discuss challenges in the interpreting infant feeding research. Early adiposity rebound. Early signs of metabolic complications. Then we will move to the early interventions, which can reverse these coming danger. And lastly, we will talk about a case study from Gaza, which is much related to our topic. So when we are talking about the first 1,000 days of life, this quantum is running between from or before conception till the child's second birthday. And here we have a multiple of windows or multiple of critical period. Let's first identify what is the critical period. The critical period, it's a period at which certain organ needs a certain nutrients that should be supplied at that particular time. And if these nutrients are not supplied at that time, irreversible damage and permanent damage which will occur. So I will give a very fast and common example, which is the NTD in neural tube defects such as spina bifida and encephalopathy, which usually occur with the children of who has his mother suffered from folic acid deficiency in the first 3 weeks, even if before she knows that she is pregnant, because by the third week she has not means usually women they recognize that they are pregnant after 4 weeks, after 1 month of the conceptus. So here we have a window which is very critical. Then during the conception in the first, second trimester and the third trimesters, we have a multiple critical periods where certain damage or insult can have has impact on the entire life. Pregnancy to birth means, especially in the first year of life, infancy is very critical, especially the first 6 months of life. Then we will move from infancy to the second year of life, where we have, it is a fast window of growth in which we have brain development, organic growth, and also programming, metabolic programming occur. So any insult or any the device of the insult, any means supplementation of good things at this period or this window can has a lasting impact. So we can say that this continuum is online with the Doha Doha hypothesis, which stand for the development origins of the health and disease, in which Parker and his colleagues they have identified that environmental or early environmental exposure can have a lasting effect and permanent effect on the gene expression and metabolic programming, which can lead to risk diseases such as type 2 diabetes, cardiovascular diabetes, and other metabolic diseases. So here we are talking about the macronutrients and maternal nutrition. And here, the amount of the energy that should be given to the mother during pregnancy, of course, it is different from when she is not pregnant. So, in the first trimester, there is no any increment or significant increment in the energy intake. In the second trimester, there is increase of around 340 kilocalories per day. And in the third trimester, we are having, or she should take more than 450 kilocalories per day. In the protein, usually the adult or non-pregnant adult usually is taking around zero point 0.8 gram for kilogram per day. But for a pregnant woman, here, because we are building fresh new organs are forming, so here we should increase, and this increase is not much bigger, point 0.8 to 1.1 gram for kilogram is not a big increment, but it is increment. Balanced energy protein supplementation, usually, especially in the low income countries, the concentration, because of the higher cost of the food items, which is high in protein, usually they are avoiding buying these things, so their concentration only in the energy. But here, when we are balancing the energy and the protein supplementation, we have means increasing in the birth weight by around 41 grams, and sometimes it can reach to 80 grams, and there is a reduction in the small for gestational age by around 30%. Docosahexaenoic acid supplementation, which is very essential amino acid, support neural and retinal development, lower the preterm deliveries by around 40%, which is very good reduction. Gestational weight gain guidelines. The Institute of Medicines, they have a guidelines in which they have used the pre-pregnancy BMI as a roadmap for how much a pregnant woman should increase. The higher the BMI, the lower of the gestational weight gain. So, for example, obese women should increase between 5 to 9 kilograms by the end of her pregnancy, and the vice versa with underweight women, BMI less than 18. 18.5, so she should increase higher, or she should gain higher amount of weight, which can reach to around 18 grams. So both the extremes, little or too much maternal energy intake, raise the obstetric risk. Under nutrition, for example, leads to intrauterine growth restrictions. Overnutrition lead to macrosomia. Macrosomia can lead to cesarean delivery, and also shoulder dystocia. And here are some of the most important micronutrients that we should take into consideration when we are talking about the critical periods, either before the pregnancy or during the pregnancy. Iron and folate supplementation has been related to a reduction in the anemia, and especially iron deficiency anemia, by around 70%. Anti-D's reduction, especially with folic acid supplementation, can reach to 60%. And we noticed that in most of the countries which has adopted the wheat flour fortification, in which folic acid is a key player. In these countries who have adopted this policy, we have noticed that there is a good reduction in the NTD. Iodine supplementation prevent cretinism and protect the offspring IQ. Usually, iodine deficiency is very much linked with the reduction in the IQ score. Calcium supplementation reduced the preeclampsia, which is very critical situation in certain groups during the pregnancy. So there is a significant reduction by around 50% of the preeclampsia prevalence when we are supplemented with calcium. Also, there is a good reduction which can reach to 20% of preterm deliveries. Vitamin D can lead, of course, to the increase in the cholecalciferol concentration and also may lower, but there is a mixed evidence related to vitamin D. It is not a strong evidence such as we have seen with the calcium. The zinc, of course, moderately, and it's under investigation. Things are coming related to the zinc, how it's important in preterm deliveries and how it can reduce the prevalence of preterm deliveries. Vitamin B12 and choline. Choline is is a methyl donor. So it can be converted to betaine, and betaine can act like a folate especially in the brain cell, especially and this is like a gift from God. Usually the folate is the methyl donor for keep the folate cycle running, the methionine cycle running, and also the thymidylate cycle of the DNA replication is running. We need this type of methylation. Vitamin B12 serve as a cofactor for methionine synthase. So this support the methylation of the DNA can adjust and regulate certain hormones such as insulin like growth 1 and other important growth factors. Here we are talking about the global burden of malnutrition, the either sides of malnutrition. So either obesity or undernutrition. 40% of the pregnant women worldwide, they are anemic, and majority of the anemia cases, they are iron deficiency anemia. Almost 25% of the pregnancy occur amid iodine deficiency. Even when there is, a programs of salt iodization program exist, but still some of the communities, especially who they are far from the sea, because the sea and the seafoods and the sea even atmosphere is full of iodine. Usually, these communities, even with the iodization of the table salt, it is still exist. 9 to 12% of the productive age women are underweight, while 40% are overweight or obese. This is, and when we have different form of malnutrition here, and when they are clustering in the same country or even the same house, this is add another layer of challenges to the policymakers, because they need to tailor different intervention programs instead of one size fitting everyone. 22% of the children, around 150 million children under the age of 2, they are suffering from stunting worldwide. Both extremes, as I said, obesity or undernutrition can feed the transgenerational cycles of malnutrition and non-communicable diseases in the offsprings and the coming generations. Mechanism, when we are talking about the mechanism, here we are talking about four ways that can feed or alter this window either positively or negatively. So the epigenetic modification, folate, B12, B6, choline, some of them they are coenzymes, some of them they are methyl donor. B6 is a vasodilator, helps in the expansion of the placenta with the increment of about around 50% in the plasma volume, or 30% in the increase in the volume of the RBC. So all these nutrients is very essential, as I said, for the methylations and the regulation of certain genes, for example, Ig, F1 and F2. A placental nutrient transport. So, a placenta is not just, inactive pipe or passive pipe. No, it is very active. Certain nutrients can pass through, and so the vasodilation is very important. Reduction in the protein can impair the reduction in the protein intake, and deficiency of the protein usually is linked with the affect the four transport systems. Amino acid usually they have four transporting system. So these amino acids transporting, or the transporters themselves, they will be affected, and other important nutrients will be also affected. Zinc is very important for mitochondrial functioning at the placenta, and this also will be affected. Endocrine and inflammatory signaling. Maternal hyperglycemia. So when we have obesity, we have uncontrolled diabetes, gestational diabetes. There is a flood of glucose in delivered to the baby through the placenta, and here this put a load on the tiny pancreas of this fetus. So it start working early, the pancreas, to produce insulin. So this is, this is a very critical situation in which at this age, at this tiny pancreas, we have a higher level of insulin produced from the pancreas of this fetus. And also the leptin signaling, raising later obesity risk also, they are altered. Gut microbiome, the metabolites of the microbiome, which is still, it is a new era of investigation, is can cross the placenta and sometimes help in the priming and helping in the immunodevelopment for the fetus. Intervention with the proven benefit. So these are the major interventions which has been it has been reported with a significant improvement in terms of birth weight, in terms of preterm deliveries. So balanced energy protein has been associated with increase in the birth weight by 40 to 80 grams. Okay, and there was a reduction in the preterm delivery by around 30% when we are giving a balanced energy protein. Iron folic acid fortification associated with reduction in the anemia, and the reduction can reach sometimes to 70%, and there's also improvement in the birth weight by 30 grams. Multiple micronutrient supplements associated with increase of 40 grams in the weight and reduction in 12% small for gestational age or preterm deliveries. Calcium supplementation, as is said, with shown a remarkable and significant reduction in the preeclampsia. Vitamin D anti-inflammations increased the weight of the birth weight and reduction of the preterm deliveries. DHA, docosahexaenoic acid omega 3, has been associated with remarkable reduction in the preterm delivery, especially very preterm, less than 34 weeks. Lipid-based supplements is shown a very good increment in the birth weight by around 50 grams, and reduction in the stunting and the preterm delivery. So the long-term intergenerational consequences. Early life undernutrition is linked to 4 to 8 fewer in the score or the points when we have undernutrition. And 1 year less schooling. Either he entered the school late because he is not have the mental capability, or he dropped school. So usually the children who has been during this stage or this window from 0 to 2 years has been suffering from undernutrition or nutritional insult during this period. Usually they have lower score, IQ score, or 1 year less schooling. Lower birth weight predict higher adult blood pressure. Here I'm talking about the systolic blood pressure. There is, with lower birth weight, with each month or each week in the reduction in the gestational age, there is increase of 2 to 4 units in the systolic pressure, and also greater type of risk of type 2 diabetes, maternal obesity, and excess gestational weight gain raise offspring obesity by around 20 to 30%. Dutch famine, which is usually a good example. It happens in the Second World War, and still we are talking about what is happening at that time. So I think what is happening in Gaza, it is despite all the sorrow and the pain, still we, as a scientists and researchers, still we can get much information from these, and can tell us how these situations and hellish conditions affected our life. The Touch famine cohort shows persistent IGF-2 hypomethylation. Hypomethylation, it is the opposite of methylation. Methylation usually it is like small chemical sticky notes that control the genes. So when we don't have these sticky genes, so we have a louder genes which can be expressed, and IGF-2, for example, can be expressed. And here it is not instant effect. It can last for 60 years, for example. The Dutch or the people in Holland who has suffered, or who were born at that time, or their mothers were pregnant at that time, they have till the age of 60 changes in the genes, and they have allowed their genes of IGF-1 and IGF-2. Epigenetic marks can pass across generations, reinforcing cycles of malnutrition and metabolic diseases. Here, difference between breast milk and formula milk, it is, I think most of us know the difference. Something gifted from God. It is natural. It is more than 100 nutrients and 100 factors, either immunofactors or growth factors, still under investigation. It's a nutrient composition of the milk. It is usually, when we are talking about the human milk, it is very dynamic. It is changing from within the single feeding. In the beginning of the feeding, we have something, and by the end of the feeding, we have something different. Through the day, and here many factors. How's the composition changing? It depends upon, for example, the age of the child, the gestational age. If he has born, for example, full term or preterm, you know that. For example, I will give very fast example. DHA, eicosahexaenoic hexonic acid, and eicosahexaenoic bentonic acid, and deicosahexaenoic acid. Both of them, these are essential long chain fatty acids. They are present in higher amount of in the milk of the mother who has delivered a preterm infant. It is higher than the full term infant. Why? Because there is a condition, retinopathy of premature, which is usually retinopathy is the maturation of of retina occur in the last week of the gestational journey. So he missed because he has been delivered maybe 36 or 35 or 34. So he missed these periods where the maturation of the retina usually occur. So God give the mother of this child the ability to produce more the DHA and EPA to compensate the losses of the in the last weeks. So, as I said, it is very dynamic. It is not static. The vice versa with the formula milk, it is very static. And they are trying to mimic the human milk, but still there are some of the things which will never be present in the formula milk. So when we are talking about the colostrum and the mature milk, Colostrum usually it is a yellowish in color because of the higher amount of vitamin A present, which can give this color. Also, the thickness, it is usually the colostrum is higher in the protein, not in the fat. Many of the people they think it is higher in the fat. No, it is higher in the protein. The energy output of the mature milk is higher than the energy of the colostrum, but the protein content in the colostrum is more almost the double. The IgA almost 5 times greater than the mature milk. The lactoferrin, which is very important carrier of the iron, and also it has uh, bacteriostatic activity. It's also more than the double in the colostrum than what we are having in the mature milk. Oligosaccharides, immunofactors, immunoglobulin A, which is the major secretory antibodies present in the human milk, is also there. Different growth factors are present in the human milk, and still investigations. And day by day, we are knowing about the miracles of the human nutrition. Significance to health professionals and policy makers. Systematic reviews and meta-analysis are increasingly used to summarize the evidence for practice and policy making. And here, this is, this it is a meta-analysis in which it studies the how the duration of breastfeeding is associated with overweight. And as we can see, there are different studies with odd ratio and CI, and finally by here in the bottom we have, let me just put my pointer in this one. Okay, here we have the combined, which is a combined estimates of all the studies, and it has also odd ratio and CI. When we look at the odd ratio, most of them is they are below than one, and usually when we have one, there is no association, and if it is less than one, we have a negative association. Higher than one, it is a positive association. So here we are talking about two different two opposite things. The longer the duration, the lower is the risk of overweight. And here, so most of them they are less than one, which is very good, and imply that there is a negative association between the duration of breastfeeding and the occurrence of overweight. The narrow of the range between the CI, the two extremes, this is also imply the certainty about our result or their results. So here we can say that there is, let us move this one because it will summarize. We can say that there is, from this result, we can say there is, with each month increase in the breastfeeding, there is a reduction in the risk of overweight by around 4%. 1 minus 0.96, that gives 0.04, which is can be translated to 4% reduction in the risk of overweight with increase with each with increasement by 1 month or in breastfeeding. So here, breastfeeding as a shield, the long-term defense against obesity. I will go direct to the second study in which we have, they have 159 studies from the ages from 1 to 9. They have done the first part in which they have included the relevant study, and the risk reduction of obesity was around 27%. Okay, here it's the same thing. Okay, this one and this one, they are the same. But after adjusting for co-founders such as socioeconomic status, there has been very minor reduction in the risk reduction from 27 to 24. And here with elimination of publication bias, and applying very strict criterias, they have been identified 15% risk reduction with the increasement of 1 month of breastfeeding.
Dr. Ihab, we
Uh,
have 2 minutes.
okay, 2 minutes. Okay,
Yes.
so this is almost the same thing. Here we have the dose effect in which no pregnancy, so almost no lactation, or no breastfeeding, so almost neutral. But here, breastfeeding 3 to 6 months, we have almost 4% reduction in the risk. And here, with exclusive breastfeeding for more than 6 months, we have significant reduction in the risk of overweight, which can reach to around 33%. The mechanism is very related to the protein intake, insulin production, IGF-1, and lower breastfeeding are lower in the fed infants when we are comparing breastfed and bottle fed. So they have higher level of insulin. They have higher level of insulin growth factor 2, responsive to the hunger and satiety. Usually, the breastfed infant, usually and the communication between the mother and the infant, it is very strong. So he can do some type of cues in which either in satiety, fullness, or in hunger, and she can understand by when he is rolling his mouth or his head away from her breast, that he is satiated now, he is full. So, but these things usually does not happen with the bottle feeding. So this type of mechanism, which is sometimes related to the hormone leptin and ghrelin, will be affected, and this regulation mechanism is also affected in endocrine programming during critical period of growth, also affected. And here, this is an example of the difference between a human milk, unmodified cow milk, or the high protein formula. We can see that excessive protein intake, for example, almost triple. This associated with increase in the insulin-like growth factor 1, which can lead to the accumulation of more fats, and of course obesity. And here we have a child obesity, especially at a critical period of life. So already the mechanism already I have explained. And here this will take us to the which is early adiposity rebound. Usually, there is, when we look at the graph, this is the first day of the first weeks of life. We have acceleration in the growth, and by the second year we have like a reduction. We have like a reduction, and this we have the nadir, the lowest point of weight gain and height gain, and after that start the growing of the infant. Sometimes, usually this rebound, BMI rebound or adiposity rebound, usually it is occur by the age of 5. But some of the children, they have an early adiposity rebound, which is related to bronchoprogramming, nutritional insult during the pregnancy, or in the feeding practice of the first year, which can lead to very critical situation and dangerous situation, which is early adiposity rebound. Means adiposity is more fat is accumulated at the early age, which can be lower than 5, and more critically if it is less than lower than 5 and less than 3, that will be more dangerous. So here, these are the modifiable factors and non-modifiable factors. Parental genetic, sex, preterm history. This is, of course, non-modifiable factors. And we have the modifiable factors: maternal BMI, nutrition, rapid infant growth, sleep cycles, and all these things which has been related to the childhood obesity, which can be adjusted. And here it is the window for adjusting all the modifiable factors to correct the things as early as possible. And here the sleep and activity. Ghrelin increases and leptin decreases. This is with short sleep duration. Sedentary behaviors promote visceral fat accumulation in toddlers, and inverse relation between the sleep duration and the abdominal fat in children aged 12 to 36 months. Meeting 24-hour movement, sleep activity, or sleep activity and sedentary. These are 888. So we need to adjust so that we have a regular ghrelin and leptin level. This is beyond the childhood, the long-term prognosis of early adiposity rebound, certain organs affected because the programming is wrong. So this led to type 2 diabetes, metabolic syndromes, and hypertension and cardiovascular diseases. Uh, these are already
I
uh,
think this time is over, Dr. Ihab.
Okay, one second. So the
Okay.
socio-economic context of the air inequity, drivers, food insecurity, lack of physical activity, infrastructure, and chronic states. Uh, Here, this is the window where we can do interventions and certain breastfeeding, preconception, during the pregnancy, breastfeeding, especially in the first 6 months of life. And here I'll come to the end of my presentation, in which we are presenting here a case of our work during the war. She is the work of my student in the master degree, where she is studying the Gaza birth outcome before and during the war. And here it's a comparison between before the war and the after the war, the birth outcome among the Gazians. For example, there is, before the war, the low birth weight delivery was 9.7, but now it is 16.8%. A preterm delivery before the war, was 7.6, after the war, almost 16. Stillbirth 0.6, now it is around 7.3. A cesarean delivery very much high. It from all more than the double, 22 to 54.8%. So the conclusion, a window of opportunity, goal empowering families with evidence-based support to build up a healthier generation. Key takeaway, intervention is the window do not just affect the size, they program metabolic health for a lifetime. Thank you very much. Thank you for giving me the chance and giving me extra time. Thank you, Dr. Muhammad, Dr. Marwan. Thank you, everyone.
Th- Thank you, Dr. Ihab. Thank you for a valuable presentation and valuable topic that we are need in Gaza, especially in this situation. Actually, we have different conditions that can affect every pregnant and lactating woman in Gaza. But actually, I have a question for you, Dr. Ihab. That you
Yeah.
know that hot weather and hot media that may affect the pregnancy and outcome of the pregnancy, and may lead to congenital anomalies. Do you think that living under the tent in Gaza that may lead to such that condition? Because actually we have a high rate of congenital anomalies. We have a very low birth weight. We have a cleft palate, a very large number of infants, newborn infants with a cleft palate in Gaza. This is not a normal conditions that we have seen in before the war. Before the war, we have more than 4,000 birth rates every month, but now we have
Yeah.
less than 2,000 per month with a high rate of congenital anomalies. Do you think that, do you agree with me for that?
Yeah, I think it is, I think this is a very good question. This is a very important concern. And I think I discussed this with a few of my students and other colleagues. It is a multifactorial. It's a multifactorial. So the heavy weapons which have been the gas and showered by with the toxic chemicals, toxic radioactive materials, that might be the first reason. The second thing, from nutritional perspective, I'm saying that, especially in the time of let us say March, April, May, June, in the time of the famine, the peak of the starvation, most of the mothers, especially the pregnant mother, when there was a scarcity of food, they used ready-to-use therapeutic food as a source of food. So instead of taking one or two sachets or bags, they have taken maybe three or four. And when you are calculating the vitamin A concentration in these sachets,
It's
which
very
can
high.
it can cross the UL, the ultimate
Yeah,
level.
yeah.
It can
It's
cross
very
the
high.
UL. So the enemy, the Israeli aggression is number one. The second might be the exaggeration or taking extra amount of the vitamin A as a source of food. And I'm not blaming them. They don't have the information. They don't have the food also. And
Yes.
also the environmental situation, the canned food can be also another example. So all these things can, can cause a nutritional insult, can alter the gene regulation in that which I so it is like small tags that control certain genes. So these tags now they are not existing with no folic acid, no B6, no choline, no betaine. All these things they are missing. So we have abnormal gene. We have a louder gene which can disturb the normal journey or normal replication or thymidylation cycle.
Thank you very much, Dr. Ihab. Just one information that I can add to this topic. Actually, until this moment, we have about three out of pregnant women out of every 10 pregnant women they are facing and they are suffering malnutrition. Until this moment, we have a high rate of malnutrition among pregnant and lactating women. Until this moment, this is seen. Obviously in Gaza Strip and especially in the displacement camps. I think we need a lot of actions, especially that healthcare providers until this moment just focusing on iron and folic acid as a main supplements for mothers and not focusing for the other micronutrients. Thank you very much,
Yeah.
Dr. Ihab. Now we are moving to the
Thank you.
second